Thank you very much for coming to today's neuropsychiatry meeting. It is the penultimate neuropsychiatry meeting of this term. The next neuropsychiatric meeting, which was scheduled for December the 12th, has unfortunately had to be cancelled, but we hope to be able to reschedule that speaker for the new year. But we do have an extraordinary, meaning out of the ordinary, but of course, hopefully extraordinary in the conventional sense as well, meeting on Friday the 1st of December, which I'll tell you a little bit about at the end of this meeting. So I'd like to thank everyone for joining, and I'm really delighted today to be welcoming our special guest speaker, who is Jesus Ramirez Bermudez, who's joining us from Mexico City today. Jesus is a medical specialist in neuropsychiatry at the National Institute of Neurology and Neurosurgery of Mexico. I was lucky enough to join Jesus at the beginning of this year in Mexico City to have a look around his institute, and it's really a sort of an interesting mirror of the National Institute for Neurology and Neurosurgery that we have in this country. And I would say that one of the really salient differences between the two institutions is I had a very strong sense that neuropsychiatry really was at the heart of the institute in Mexico City, and I'm sure Jesus will tell us a little bit about the position of neuropsychiatry there. He's a doctor of science from UNAM, where he's a professor of scientific methodology in the Masters and Doctorate in Medical Sciences program. He's published far more than 100 scientific papers in the field of clinical neuropsychiatry and neuroscience. And he's also a highly published author. He's the author of the treatise Principles of Neuropsychiatry, the novel Paramnesia, and the books A Brief Clinical Dictionary of the Soul, A Dictionary Without Words, and Depression, the Darkest Night. So without doubt, a man of many talents. And these books tend to explore the borders between sort of clinical narrative and science essay. Jesus today is going to talk about psychosis in the neuropsychiatric borderland, the Mexican experience. Just a few housekeeping notes. We are recording the meeting. Please mute all your microphones, and if you can switch off your cameras until the Q&A session at the very end, that would be great. Please do not take control of the slides, as this can disrupt the presentation. So you can ask a question by writing it in the conversation, or by raising your hand, and at the end I'll ask people who've raised their hands to switch on their cameras and ask the question face to face. And if anyone needs captions for the hearing impaired, please select the 3 dots on the toolbar and then press turn on live captions. So without further ado, I'll give you Jesus Ramirez Bermudez talking about psychosis in the neuropsychiatric borderland.
Well, thanks a lot for that presentation, Tom. I believe you can see my presentation now. So first I want to show my gratitude to Tom Pollack and Timothy Nicholson for this opportunity to share some ideas and some research from the National Institute of Neurology and Neurosurgery, where I work with a group of colleagues, and to think together about this problem, psychosis in the neuropsychiatric borderland. So the presentation is an academic sketch aimed at outlining in general terms how the study of psychosis is conducted within the context of clinical practice and research in a neuropsychiatry unit in Mexico City. Through a clinical gallery, I will seek to provide an empirical foundation for the theoretical analysis of psychosis. In some cases, the impact of focal lesions will compel us to consider neuropsychological models based on functional specialization. And on the other hand, I will discuss cases of autoimmune psychosis, emphasizing delusions of misidentification and the Cotard delusion. I hope this will lead us towards pathophysiological mechanisms that require models of functional integration and ecological settings. So a few words about the Mexican experience. So if you come with me to Mexico City, where I work, and we go to the south of the city, nearby the National University, and even close to some archaeological sites with like the Cuicuilco archaeological site, which is 3,000 years old. Well, you can visit the National Institute of Neurology and Neurosurgery, which is a facility with a neurosurgery department, a neurology department, and a neuropsychiatric unit. Now, there are a couple of things I want to say about the geography of the institute. The first one is that in this area, in this part of the city, we have another institutes of health, like covering problems like oncology, cardiology, and so on. Uh, we have also large general hospitals. So my colleagues working there, when they see patients that they think require specialized neurological care, they send those patients to my institution. But also in the same area, we have an institute of psychiatry, and we have the largest psychiatric hospital in the country. So also my colleagues in psychiatry, when they see patients that they think have neurological problems, they will send it to the institute. So perhaps that can explain why we have some large numbers uh, on these specific populations, no, of neuropsychiatric patients. Now, inside the institution, the Institute of Neurology, as said, we have an emergency room, an intensive care unit, and so on. But we also have a neuropsychiatry ward, which is a small facility with 24 beds. And we take care there for patients with classical cognitive neurology problems, dementia, and all sort of patients with psychiatric problems, which are under a differential diagnosis. Sometimes they are patients with primary psychosis, or they can be patients with brain-based psychiatric illness. Anyway, we also have a large outpatient clinic and a lot of consultation liaison. So surely in this context of this meeting, you can agree with me that in the neuropsychiatry philosophy, we don't see psychiatric constructs and neurological constructs as mutually exclusive. Instead, we see a great overlap between these constructs. So first, I should clarify my concept of what counts as a psychiatric construct. So to me, it is a clinical pattern which is defined by disturbances in the realm of the psychological. Now, this is a conceptual discussion, very interesting. What is the psychological? So for me, it entails behavior, cognitive, affective functioning, and subjective experience. And on the other hand, we have clinical patterns, which are defined by cellular lesions or physiological disturbances affecting the nervous system. And then we would speak of a neurological construct. So my patients usually fulfill both definitions. And going into the problem of psychosis, of course, we like very much the history of concepts. I will not spend too much time with this problem now because it would take us a lot of energy and time. But I would just like to highlight these concepts from Germán Berrios in this famous article uh, in which he shows the conceptual evolution of psychosis that coming from the concept of delirium in the Roman period. Uh, if you have the time, please read the Epidemics by Hippocrates, in which he makes these clever descriptions of hallucinations, delusions, and other psychotic symptoms in the context of fever and infections, no, in the Roman in the Greek context. Anyway, the concept of psychosis that it was built in 1847 use some symptoms from that conceptualization, but also from the concept of mental alienation, as was developed by Pinel, and these strange categories, no, like the Vesanic dementias, as known in the 19th century, dementia was divided into organic dementia and Vesanic dementias. So, well, these were the sources for the concept of psychosis, highlighting these these core symptoms, no, delusions, hallucinations, and thought disorder. Now, in a more contemporary view, uh, I think you can agree with me that in psychiatry, but also in neurology and in medicine in general, we make a progressive conceptualization of disease from concept that entail a lot of uncertainty and which can be viewed as practical kinds. For instance, uh, signs and symptoms, which would be the initial indicators of suffering and disability. And then we go on through stage two, 3, 4, and 5, going through general syndromal descriptions. Here we would have the concept of psychosis. Then the concept of proto-disease, which would be nosological category defined as clinical patterns with well-defined phenomenology, clinical course, subtypes, comorbidity, epidemiological features, treatment response, a preliminary pathophysiology. And here we find, of course, bipolar disorder, schizophrenia, and most of the constructs that we conceptualize as being primary psychiatric disorders. But then we can move on to a more precise characterization of disease within a classic anatomopathological tradition, where we find physiological abnormalities and cellular lesions, and even a molecular characterization of the disease. So in the case of psychosis, we have to keep track of this progressive conceptualization, because we will have some concepts that are really on stage 1 and concepts that are maybe on stage 5. For instance, if we talk about psychosis in a patient with a familial form of Alzheimer's disease by due to a mutation in the presenilin gene, well, we could link level 1 and level 5 in this conceptualization. So now I would like to go into clinical cases, uh, showing this issue of levels of diagnostic reasoning that perhaps is similar to something that you do in your own institutions. So we like to go through syndromic or syndromal. I don't know exactly what is the word you use there in England, but so we have to diagnose syndromes. And here we need a careful phenomenology, a careful psychopathology that often goes beyond DSM categories, because most of the specific phenotypes that we are using, like for instance the Charles Bonnet syndrome or peduncular hallucinosis or the Capgras delusion, or well others, are not in the DSM, but they have some scientific value for us, as they allow us to make a specification of the psychopathological pattern. For instance, this first case was a patient diagnosed as having schizophrenia for some years, but then he started showing some motor weakness, even falls. And the neurological examination revealed that he had generalized hyper reflexes in the neurological examination, and general weakness in the limbs. So this led us to investigate the case, and the topographical diagnosis would be a disease in a white matter disease, no? And the etiological diagnosis would be metachromatic leukodystrophy. Also, at the syndromic level, we will speak of a major cognitive disorder, because this patient truly had, so to speak, dementia precox, no, uh, uh, dementia in youth with prominent psychotic symptoms. Now, the second case I want to share with you is this other case in which the presentation is paranoid delusions. This was a patient that even had aggressive behavior towards his neurosurgeon because he thought he was having an affair with his wife. And this patient did not have hallucinations, only this kind of delusions, but also he had an important red flag that led us to make a brain image in the case. So what we have here is a problem of hemi-neglect. For instance, this patient was a driver that used to drive a trailer all around my country, which, as you know, is very, very large. So although he was an expert in geographical cognition, spatial cognition, he suffered from accidents 3 times, but only in the left side of his trailer. So this led to the hypothesis of hemi neglect, and this, of course, affected visual attention, but also auditory attention, and even by memory. If we ask the patient, for instance, what are the cities in the east coast of Mexico, where is the Gulf of Mexico, he would remember perfectly the cities like Veracruz or the Yucatan Peninsula, where we find, for instance, Cancun. But he would not remember the cities in the Pacific coast, in the west side of the country, you know, where we find the Baja California Peninsula, and also cities like Acapulco. Even by drawing the map, he would ignore the Pacific coast. No, so well, this is the kind of red flag that tells us that in this case, psychosis is linked to focal neuropsychological disorder. And this is a red flag to make further research of the case. The topographic diagnosis in this case is a large lesion, a neoplastic lesion in the right hemisphere, affecting the temporal lobe, and even with some edema on the parietal lobe, and probably accounting for the hemi neglect phenomena. And the etiologic diagnosis was glioblastoma multiforme. Now, I'd like to go further into another kind of case. This is not a case where we can find a neurological diagnosis, but we can still make a phenomenological account, a cognitive study of the case. Even we can make some brain imaging to obtain some correlate of the psychopathology. And well, this is the case of Mrs. G, who reported that her children had been kidnapped, and that the persons living with her are in fact their doubles. The imposters are also kidnapped victims who had their memories erased and an electronic device implanted, which is why she tries to get along with them, because she has these mixed feelings towards these children. No, she denies that they are her own children, but she treats them well because she thinks they are also victims. Now, the kidnappers also implanted a chip in her through which they can alter her perception of reality, and in turn make her real children present themselves looking like strangers. So that's why we think that in this case we have the Cotard, I'm sorry, the Capgras delusion and the Fregoli delusion. Now, she claims that several customers at her shop are in fact her children, who ask a series of questions disguised with other words as a way of testing her. So the patient must answer in a specific order to these questions to recover her family. Now, due to the undercover nature of these questions, she never manages to answer them correctly. Now, when she goes to the market, to the supermarket, uh, she spends lots of time reviewing the vegetables and other prepackaged food because she thinks this food has been replaced with products that look similar, but that have been adulterated with high fat content. So Mrs. G spends long periods of time comparing products in order to identify subtle differences that allow her to differentiate the real products from the modified ones. Because this modification in the food was carried out in order to control her diet so that the device works correctly. So this is the delusion in which we have a capgras and also a Fregoli phenomena. And well, I've never seen this kind of capgras for food, no, but perhaps it has been reported elsewhere. Now, the neuropsychological testing in the case was unremarkable when we tried to test for face recognition, face retrieval, visual memory, which were really our hypothesis for a dysfunction. But the only impaired performance of the patient was seen in the self-directed signaling test with perseverative answers, which is a proxy for failures in recognition and in the sense of familiarity that one has when we think that we already saw some specific visual stimuli. Now, the MRI was unremarkable, but the molecular imaging study revealed some hypometabolism in the frontal lobes, but mostly in the retrosplenial cortex, which is closely related to the sense of familiarity. So this is the hypothesis. Now, of course, it's just a case, so we can only draw some hypotheses from it. Now, what I want to say by this is that the method we use when studying psychosis in neuropsychiatric patients goes from this triple axis. So we go into descriptive psychopathology uh, by means of narrative accounts, by means of phenomenological interviews. So we use a lot this long tradition of psychopathological phenomenology, and also clinimetrics. Sometimes we have to develop our own clinimetrics because some of these phenomena, like the Capgras syndrome, the Ekbom syndrome, the Cotard syndrome, don't have specific criteria or rating scales. Now, we also need to make bedside exams, cognitive exams, and we follow the principles of that were developed by Peter Halligan and Anthony David in this wonderful concept of cognitive neuropsychiatry. So we try to make always hypothesis-driven cognitive assessments to test specific hypotheses of the cognitive disturbances behind the psychotic symptoms. Whenever possible, we make some psychophysiological testing. For instance, we can make some event-related EEG, or we can make fMRI in some cases as a way to make some research in these cases. At the neurological level, we will always try to track the etiology through laboratory tests, physical and neurological examination, brain imaging, and electrophysiology. So allow me to go into another case that perhaps is a little more detailed and I hope may be interesting for you. So consider this case. So the life of Julio Cesar, a 39-year-old man, took a dramatic turn when he was struck by the most excruciating headache he had endured, accompanied by an abrupt loss of vision. The medical approach revealed the rupture of an aneurysm, which resulted in a brain hemorrhage. here in the image, you can surely see these areas of brain hemorrhage in the tomography, which are affecting the Sylvian Valley, and this is the acute phase. And in the subacute phase, we can see also this hyperdense lesion in the front, in the right frontal lobe and the lateral aspect of the frontal lobe. And in the chronic phase of the disease, we can see by means of the FLAIR MRI this hyper intense lesion affecting the frontal operculum, the anterior and posterior parts of the insular cortex, and also the temporal and parietal cortices in the right hemisphere. Also, we have a bilateral occipital lesion. So this patient is blind. No, he cannot see. He was assessed by the ophthalmology department, so we can be sure that he cannot perceive light. We even made this event-related potentials, no visual evoked potentials that confirm that the light stimulus doesn't pass through the retina, because he even had hemorrhages in the retina. That was the severity of this subarachnoid hemorrhage. And by means of this delayed cerebral ischemia, he develops these lesions in the right hemisphere. So he's blind, but he has two phenomena that are worth of analysis. First, he has some nihilistic delusions. He thinks he's already dead, that he smells like being dead, that his dead uncle is appearing and talking to him. So he's severely psychotic for some weeks. But even when this recovers with the use of an antipsychotic, he remains with a striking phenomenon of anosognosia, in which he denies completely being blind, and he even shows aggressive behavior towards his wife, because he wants the keys of the cars so he can buy some beer in the store, no, in a nearby store. So this kind of behavior is what brings him to the uh, neuropsychiatry unit. And I could follow up the case for 6 months, and it's let's say the case with the longest phenomenon of anosognosia that I've seen in the context of Anton syndrome. Now, there are, of course, some evidence, some large evidence of relationship between right hemisphere lesions and anosognosia, like in these studies by Boguslavsky and colleagues. But also in some experimental studies, anosognosia has been examined in patients undergoing the WADA test, no, an intracarotid amobarbital injection. And when the right hemisphere was inactivated in this study, 88% of the patients were unaware of their paralysis. No? So there seems to be a large amount of functional specialization, in this case, contributing to the explanation of the neuropsychiatric problem. Because one could discuss if this denial of his own blindness is or not a delusion. You know, I'm sure this would be controversial. There would be experts posing that yes, it is a form of delusion, or not. It is a different phenomenon. So we can discuss that later. Anyway, anosognosia has been explained also by a predictive processing account as follows. So top-down visual percepts are predicted according to the priors, but an impairment in prediction error minimization causes a failure in the person's inference about their own blindness. Now, this Bayesian predictive model of anosognosia has been tested empirically in patients after right hemisphere stroke. So EMI neglect affects the updating of prospective beliefs about the subject's abilities, and white matter damage in the superior longitudinal fasciculus connecting the temporoparietal junction and the ventral frontal cortex leads to dysfunction of the ventral attentional network. So once again, this specific topographic diagnosis contributes to the explanation of the phenomenological problem that we see at the level of psychopathology. Well, now, so far, I would like to take a minute to go into another clinical phenotype, a very classic phenotype from the from the tradition of psychopathology, which we have the opportunity to study through several cases in the last 20 years. Allow me to talk a little about the Cotard syndrome. I'll just have a little coffee with my Ramon and Cajal cup if you allow it. Well, anyway, the Cotard syndrome has been, of course, in a lot of neurological diseases, but typically it cannot be counted as a focal neuropsychological syndrome, right? Because it can also be seen in patients with schizophrenia, with psychotic depression, and bipolar disorders, and other conditions. So it can be presented in the context of focal brain lesions or in the context of more widespread multifactorial disorders, psychiatric disorders. So that's why we think it calls for an ecological framework that could encompass the level of the brain systems, but also the level of the organism, the level of sociocultural systems, and so to speak, the system of relationships of the patients, both biological, cultural, symbolic, and so on. So, well, a couple of cases just to highlight this kind of problem. Here we have a patient with semantic dementia that we studied with Dr. Mario Mendez from UCLA. So the patient has frontotemporal dementia, specifically this variant, semantic dementia, and he started missing the semantic concepts related to his own body. And in this context, he develops nihilistic delusions that, in this case, are closer to somatic delusions. So they are nihilistic, but mostly somatic, because as we will see, some patients with Cotard delusion deny aspects of their own body, and others deny aspects of the world, and some deny both kind of aspects, personal and extrapersonal aspects. Now, this is another case, a case studied by my colleague Miguel Restrepo in Colombia, and which we published in a book dedicated to images in clinical imaging in neuropsychiatry. So this is a woman with an insular disease. You can see here an hyper intense image in the anterior part of the insular cortex, and she was treated as having autoimmune encephalitis unsuccessfully, and the final diagnosis was a low-grade glioma. She also developed this Cotard delusion. Now, trying to link the insular cortex and the Cotard delusion, we publish this case that will provide us with this so-called two-factor account, which is, of course, the subject of many discussions between experts. On one hand, there are these proponents of one-factor accounts like Phil Gerrans in Australia or Phil Corlett in the US. But well, I followed the conceptualization by Dr. Max Kohlhart in Australia. We are right now working in a paper with him on this two-factor account. So this patient that I am going to talk about has a problem of an autoimmune encephalitis, although we didn't find the anti-NMDAR receptor antibodies, but he fulfilled the probable level of description for autoimmune encephalitis and autoimmune psychosis. So he was treated with immunotherapy. But well, before the immunotherapy, he had this very peculiar somatic delusions. For instance, he would say that the left side of his body was disappearing, his left lung, his left kidney. Those were his words. And he also had other kind of delusions, like, for instance, guilt delusions. He felt responsible for changes in the world, bad government. And well, then of course he went into this full account of the Cotard delusion, with the delusion of being dead. And of course, this not deprive him from looking for sharp objects to cut his neck and forearms, which he tried on multiple occasions. No, which is one of the paradox of the Cotard delusion, right? That the patients can uh, say that they are dead and at the same time have this delusion of immortality, leading to repeated suicidal attempts. Now, the two-factor account in this case is because we have a significant degree of dysfunction in the frontal lobes, um, as depicted by the neuropsychological testing, but also by the molecular imaging uh, studies. You can see here a significant amount of hypermetabolism in the frontal lobes, both frontal lobes, which recovers completely after the immunotherapy. And this patient also received ECT because he did not improve completely with the immunotherapy, but he recovered completely with the ECT and the immunotherapy. So the abnormal signal in the frontal lobe disappears completely, but the patient has a second factor, which is a significant hypometabolism in the insular cortex, bilateral. So for us, the hypothesis is that this dysfunction in the insular cortex uh, provides with abnormal sensations, interoceptive sensations, uh, that are the first factor that could bring, at least partially, the content of the delusion, the somatic delusion, the nihilistic delusion. But we need the second factor, would would be in this case an abnormal metacognitive reasoning related to the dysfunctional prefrontal cortex. Now, at the psychopathological level, we need instruments. So we are developing this research instrument that accounts for core symptoms and nihilistic delusions, but also a large list of features that have been shown to be important in our previous cases and also in the literature. No, like, as you know, Germán Berrios made an historical analysis of 100 cases. So this instrument includes those symptoms and others that we are studying. For instance, depersonalization, derealization, alexithymia, and so on. Now, this two-factor account can be used in other settings. For instance, to make a model of the Capgras delusion, right? So, for instance, these are cases in which we don't have a delusion. We only have abnormalities in the sense of familiarity. This patient had brain hemorrhage um, in the left cingulate cortex, leading to pathological hyperfamiliarity, very intense, that was present for about a week, and then it disappeared completely after the patient recovered neurologically. And uh, he never had a delusion. But this other patient who had a brain tumor and a brain surgery of a lesion that was affecting also the cingulate cortex, but in the right hemisphere, and also the right frontal cortex, the lateral frontal cortex. Well, this patient has delusions of hyper identification, no, as they call it. No? Delusions of hyper identification. For instance, I was the brother of the patient. The patient thought that another patient was her wife. In fact, he uh, he asked for another patient to marry them, no, being like some kind of judge there. So the other patient married my patient with the other patient, so they could consume the marriage, you know. But all of this was a transitory problem, like a 2 week delusion. And then when the patient recovered from the psychotic state, he would remain even with hyper familiarity. And this had profound changes in his personality because before the lesion, he was a very angry person. No? And after the lesion, he would be very kind and would even talk to strangers when going in the street. No? Well, now, this is another case of Capgras delusion, but here I would like to call for an ecological formulation of these problems, because we have a Capgras delusion here. We have a psychotic state resembling schizophrenia. It's a schizophrenia-like psychosis. And the patient develops catatonia and a frontal medial syndrome with problems uh, like praxia, no, for the march, uh, apraxia for walking, and also incontinence of sphincters. No, so the patient has this brain tumor affecting mostly the right hemisphere, no, the front, the dorsomedial uh, aspect of the frontal cortex, but also the cingulate cortex. And well, the patient has this very important neurobiological factor, but she also was kept in complete isolation by her mother for 7 years. So we have two factors, no? A psychosocial factor and a neurobiological factor. So the there's a lot of controversy uh, between the neuropsychiatry department and the neurosurgical department regarding the outcome. I mean, if we make the surgery in this patient, that must be done, but can she recover completely? So, well, here we have the outcome of the patient in the MRI. So we can see that the surgery was successful, and the catatonic state recovered immediately. Also, the frontal medial syndrome. And the psychotic syndrome improved a lot, but she still persisted with the Capgras delusion for another year, uh, even with resistance to antipsychotics. She has only improved in the long term by means of clozapine. So this is a case in which we need many levels of reasoning, um, many levels of analysis, including the psychosocial analysis, because we have to make, in this case, many interventions, psychosocial interventions, psychotherapy, and of course the surgery and the use of antipsychotics. Now, in the last part of this presentation, I wanted to discuss this problem, no? The problem that was highlighted by Germán Berrios in this famous article, in which he presents evidence, and that's consistent with my own practice, in which, for instance, we can have uh, two different patients with different uh, topographies of the lesion, in which nevertheless we will have the same symptom, at least superficially. No? For instance, the Capgras delusion or the Cotard delusion. Of course, you can say that perhaps there is underlying functional connectivity between these areas, but it may also be the case that the construction of mental symptoms undergoes a psychological and cultural process according to configurators of the for this construction of the mental symptom. And this implies that we need to see the history of interactions of the patient, the history of learning, uh, and also the cultural and social history of the patient, the context, so to speak. Because it may also be the case that a lesion in the same location can lead to two different symptoms. No, the same lesion or a very similar lesion in terms of its geography, leading to different symptoms. So this is the kind of things that we see all the time in the clinic, and that cannot allow us to embrace only a localizationist account. No, we can clearly say that neuropsychiatric syndromes mostly are not just focal neuropsychological syndromes, although focal neuropsychological syndromes are important models for neuropsychiatry. So I think we need, of course, integrative theories, no? Like the theories that are being developed to account for conscious experience, high order theories, predictive processing theories, global neuronal workspace theory, or integrated information theory even. No, so in the last minutes, I would like to change this approach, from focal neuropsychological syndromes to this other kind of approaches that uh, try to study the brain more globally, in more in a network sense. And the model that I will use is anti-NMDA receptor encephalitis, no, which I'm sure is very well known to all of you because of the wonderful studies that have been done in your own research centers, no, and which have been very useful for us. For instance, this concept of autoimmune psychosis, we use it a lot to test our own patients. For instance, these two patients that have the Cotard syndrome in the context of anti-NMDAR encephalitis, and which, although they have some degree of focalization, no, you can see here the MRI with this characteristic hyper intense images in the medial temporal lobes, but also the patient has a diffuse encephalopathy, encephalopathy, right? He has this delta rhythms in his brain, and even this specific sign, the delta brush sign. So the patient has a diffuse encephalopathy, and we still don't have the specific clues of why these patients are developing the Cotard delusion, but it's not strange. In our own sample, almost of our cases with this form of encephalitis have nihilistic delusions. Now, we have made our own models, focusing on the medial, parietal, and occipital cortices, because we see in these patients this significant and abnormal gradient of metabolism, with hypermetabolism in the anterior parts of the brain and hypometabolism in the posterior parts of the brain. And as known, the precuneus is very relevant for conscious awareness. No, you can see here images of a conscious subject of locked-in syndrome, vegetative state, and minimally conscious states. And this neural system can be even important to provide this first-person perspective that is characteristic of conscious states. Now, our own FDG PET studies have confirmed in larger samples. Now, this is the mathematical analysis by means of SPM analysis. So we confirmed in a larger group of patients this pattern of hypometabolism, affecting the occipital and the parietal lobes, mostly in the medial aspects, but not exclusively in the medial aspects. Nowadays, we have done a larger analysis of these cases, and we can see that this is the most characteristic aspect that allows us to make a classification of the cases. No, so the sensitivity and the specificity is not perfect, but it's better than what we obtain with MRI. Here's another case that you can see. For here, surely you can see in this case of Capgras syndrome, this abnormal gradient. No, there's a striking hypometabolism in the occipital cortex with an hypermetabolism in the frontal lobe. But even if you see the frontal lobes, you can see an important asymmetry. No? The right frontal lobe is hypermetabolic and the left one is hypometabolic. So we are doing now case studies of these asymmetric patterns, no, that are also giving us clues to understand why some patients have some specific psychopathological psychotic patterns and accompanied by some cognitive features like neglect, for instance, no, in some of these patients. Now, we already published some research on catatonia, and our latest paper with 100 cases of anti-NMDA-R encephalitis showed us that most patients start with anxiety or depression or a manic pattern. Most of them have, like 81% of our cases had psychotic symptoms, but they usually progress until they meet even the criteria for delirium or catatonia. So that item from the autoimmune psychosis criteria, the severe and disproportionate cognitive disturbance, is very important for us. Finally, we recently published this work on suicidal thoughts and behaviors, in which we see specific forms of psychotic patterns, for instance, psychotic depression. And well, what we are doing nowadays is trying to assess the outcomes after immunotherapy. No, we're having a very good response to immunotherapy on the cognitive, the psychotic, the agitation, and the catatonic aspects of the disease. This is my last slide, and in which we can see the response specifically on psychotic symptoms, hallucinations, delusions, thought disorders, psychomotor disturbances, and so on. And so, well, I don't have time now to present this integrated model. I would just like to show my gratitude to all of the colleagues, mostly psychiatry and neurology residents, neuropsychiatry fellows too, that have been doing this work that I am presenting now, and which truly are the authors of this work that I am presenting now. So, well, this is the presentation. I hope it can lead us to an interesting discussion. Thanks a lot.
Thank you so much, Jesus, for that wonderful talk. Can we see your face? If you, there you are. Excellent. Thank you. Yeah, I think everyone watching this will have the same impression, really, that there's so much neuropsychiatry or so much psychiatry, I mean, in this country, and I'm sure in many others, that's done, that just fails to even dip its toe into the level of sort of phenomenological and psychopathological detail that you do. And I just wondered, you know, so much of the research that's done now is about big data, thousands of structural MRI scans for, you know, relatively small changes that are found. And not only that, but many of the syndromes that you describe, big data approaches seem to suggest that they're not just sort of neuropsychiatric syndromes pointing us towards organic lesional problems, but actually you see them in sort of idiopathic psychosis and schizophrenia and all different disorders. And I wonder if you think, well, does this sort of big data approach lose something that's important? Is there something to this very, very focused, phenomenological approach that you take and is much more classic that we still need? I think I know what your answer might be.
Well, my own answer to that question is that these large approaches, of course, are very important to provide us with statistical data and stronger scientific models. But I think that we cannot make progress if we don't have a more detailed study of the clinical phenotypes. Because, for instance, if we work with a very broad concept of schizophrenia, or to mention just one case, no, so the constraints of the model are the constraints of the psychopathological construct. So I don't know if that leads us to some kind of tautological reasoning. No, we're trying to provide a validation of phenotypes that were developed 100 years ago. And for me, we need to go from there to more specific subtypes. No, because surely in the case of schizophrenia, for instance, we have a lot of heterogeneity. No. So probably there are multiple diseases there. I don't think it's a unified disease. That's my personal thought into schizophrenia. But I think that we can only make progress if we combine the technological progress and the psychopathological progress. And the psychopathological progress goes through these three levels, no? Clinimetrics, of course, but clinimetrics has to be informed by phenomenological research, no? That even takes the form of qualitative research, detailed interviews with the patients, etc. And the other level is cognitive research, no? But you yourselves, with all the movement in cognitive neuropsychiatry, have been really the leaders of this kind of approach.
Thank you. I think in the last couple of years, I've noticed a bit more. I'm hearing phrases like embracing heterogeneity and words like sort of back translation that are beginning to pop up. And I think that represents an acknowledgement of what you're saying, actually, that it is those very clinical signals that might drive sort of research at a larger scale. We have a raised hand from Sheldon Benjamin. Shell, can you switch your camera on?
Yeah. Hi. First of all, that was a lovely presentation, Jesus. I thoroughly enjoyed it. I think we could spend 30 or 40 hours discussing the things you brought up. But at the very beginning of your talk, you mentioned a very interesting case of a man who could conceptualize the one coast of Mexico, but not the other. I think Bartolomeo and some people like him have called that imaginal neglect. And some people with visual neglect, a few of them have imaginal neglect. I've seen a patient like that, but most don't. And I think what their group thought was if the interhemispheric white matter, or the callosum, is involved, that you're more likely to also have the imaginal neglect. This is a little subpart of what Tom was just saying. That is to say, a case report is not a case report. A case report that doesn't delve into the anatomy and the connections isn't that helpful to understand the pathology. But a case report that specifies, like many of yours do, specifies exactly what pathophysiology you can find and what the possible implications are, can be very important. So did your patient that had this imaginal neglect, did it involve the corpus callosum as well, to your recollection?
Well, according to the MRI, there was some level of inflammation there in the corpus callosum, in the fibers, in the callosal fibers, no, in the commissural fibers. So my answer would be yes. And well, first of all, I'm very glad, Dr. Sheldon, to see that you joined us today. Thanks a lot for that comment. And I hope that you can help us to conceptualize this problem, because we see many patients with EMI neglect, even in the context of autoimmune psychosis, which I think it's an unexplored territory.
Yeah. Fabulous, fabulous presentation. Amazing what you covered in 1 hour.
Thank you. I'm going to ask one final question, and before we're going to have to go, I would kick myself if I didn't ask a question about encephalitis and the diagnosis of autoimmune encephalitis, Jesus. You obviously have a great setup diagnostically there. You're able to do, it sounds like you're able to get an FDG PET much more easily than we are at our hospital, but probably some aspects of the diagnostics, particularly the blood or CSF based, I wonder if perhaps you don't have access to quite the same breadth that we do here. And I often find myself wondering, where in settings that are sort of there's less resources, or even in sort of fully resource poor settings where diagnosis is always clinical, what are the main sort of clinical lessons for diagnosing these disorders if one can't simply screen everyone with antibodies or do a EEG or MRI on everyone? What are your lessons from that?
Yes, thanks a lot, Tom. Yeah, it's one of the absurd paradoxes of the developing countries. No, we have a lot of PET imaging, but we don't have all the antibodies, unfortunately. But well, going to the clinical setting, well, we follow a lot of the studies that you yourself have done and others. No, first we committed the mistake of testing everybody. No, so the efficacy of that measure is very, very low. So right now we only go for cases with clear red flags, no, like the ones that you use in your own autoimmune psychosis criteria. No, so if a patient has an atypical form of psychosis, if the response to antipsychotics is very bad, no, as you know, now we're publishing a work that shows that perhaps the antipsychotics are not the cause, but anyway, as the clinician sees the problem, he gives antipsychotics and the patient worsens, no, even if there's not a causal relationship. But that's an important red flag. But for us, the most important red flags have been the severe cognitive dysfunction, the catatonic signs, and the abnormalities in conscious state, no, like the level of awareness. So if the patient is transitioning into a state of delirium or something like that, that is also for us an important red flag. And from there we go directly to the tests and to the lumbar puncture, no, which is the important decision that one has to make, because the MRI can be ambiguous. The EEG also give us many false positives and some false negatives. So we have to take the decision of the lumbar puncture. So, but we go through these specific red flags. Also, of course, seizures or dyskinesia are very strong red flags.
Thank you. Yeah, I think your group is the first group that has really shown really clearly that actually delirium occurs in the vast majority of these patients. And of course, delirium is a diagnosis that neurologists probably, I'm going to get in trouble for saying this, but neurologists don't like to make. But it's actually it's a really frequent feature of these patients, and actually formally sort of testing for delirium may well be a good idea. I think as Sheldon Benjamin said, we could go on talking about this for 30 or 40 hours, but I'm afraid we can't. We're going to have to finish here. But I'm really so grateful for you, Jesus, to present your experience from Mexico, and we hope we can collaborate between our institutions again. And you will be in the UK, am I right? I'm allowed to say this. Yes, at the BNPA, giving the Lishman lecture, I believe, the JNMP lecture at the BNPA, which is fantastic news. So hopefully many people watching today will get a chance to meet you in person then.
Yeah, I'll be very glad to visit London on March. Thanks a lot for this opportunity.
Thank you so much. And just a note to everyone that the next neuropsychiatry meeting will be at 5 in the evening on a Friday afternoon, the 1st of December. It's an extraordinary meeting, and it's a talk on functional neurological disorder from
It's on treatment of FND with hypnosis. So, but an Australian visiting guideline.
Okay, we have a visiting specialist from Australia who will be talking on the treatment of functional neurological disorder with hypnosis. So please don't miss that.
The one on the 12th isn't cancelled. We've got normal stepping in.
Oh, and also the talk on the 12th, which I told you at the beginning of this talk was cancelled, is no longer cancelled. We actually have a different speaker stepping in. It will be Norman Poole, who will be presenting on a topic probably to be confirmed. So thank you for turning up in person. Thank you for turning up online. And thank you to Jesus Ramirez Bermudez for a wonderful talk. Take care. Bye-bye.
Bye.